Hi, everybody, and welcome to the provider module for the Oakland County Medical Control Authority, November 1st, 2025, Protocol Implementation. I'm John Toyd. I'm the Director of EMS Operations.
I'm Bonnie Kincaid, the Executive Director. Welcome, everyone.
And I'm Amy Welline. I am Administrative Coordinator for Oakland County Medical Control.
And I'm Dr. Cooper. I'm the Deputy Medical Director for Oakland County Med Control.
Protocol 1.3, nausea and vomiting. The only change here was to obtain a blood glucose.
The next protocol is Heat Emergencies Protocol 210. There was a few typographical errors fixed, but Dr. Cooper, can you explain the treatment changes?
So in this protocol, they are asking to cool as quickly as possible via ice or cold water immersion. In reality, it's going to be very difficult to do a cold water immersion in the field. That would be just technically challenging. And so the next thing they want you to do, if that is not available, is to douse the entire skin surface with water, preferably cold water, and then fan the patient to cool them down by evaporative cooling.
Providers, you should read this protocol all the way through so you understand the changes. There is some discussion of ice water immersion, may be continued with devices such as body bags. Read through this protocol so you have a full understanding.
And in addition, the protocol talks about cooling first and transporting second. This is actually very, very important. The most important thing for these patients is to start getting them cooled down, so much so that you should not start an IV if it's going to delay the cooling. And that's also reflected in the protocol.
So the next protocol, 211, hypothermia frostbite. It has a few changes that Dr. Cooper will speak to.
So in this protocol, they want you to now evacuate the patient to a warm environment, i.e. the ambulance. If you can do it within 30 minutes, then you should leave their clothing in place and wrap them in some sort of barrier against the wind. Once they're in the back of the ambulance or other warm environment, then remove their wet clothing and dry their skin and wrap them in warm blankets. The other change to this protocol is that if a patient's body temperature is less than 30 degrees Celsius, which is 86 degrees Fahrenheit, it says gentle handling is required. And actually the reason for that is because these patients are very, very prone to arrhythmias, and that can be pushed off by jostling the patient. So gentle handling is required, and then facilitate transport immediately after that. The other thing to point out in this protocol is the location that they want you to apply the heat packs is now the axilla and the torso. Also, when giving oxygen, please keep in mind to give warm and or humidified oxygen if it's available. And lastly, the protocol says that if the patient is alert, you can administer warm, non-caffeinated beverages by mouth slowly.
The next protocol, 2.12, head injury, has some minor changes, but some interesting changes that Dr. Cooper is going to speak to.
This protocol changes some of the target blood pressure goals for adults, pediatrics of various ages. So just be aware of that. Some of them are different, and you just need to take a look and make sure you're familiar with what those are going to be. Also, it would like you to frequently reassess and keep an eye on the blood pressure. And if it falls below those target blood pressures, it reminds you that you may need subsequent fluid boluses to maintain the blood pressure above the target.
The next protocol is Protocol 2-13, bleeding control, or BCON if you prefer. The BCON protocol, the changes include adding the term junctional hemorrhage to the neck, axilla, shoulder, or groin bleeding. There was a little bit of editing of some verbiage. And just remember, caution must be exercised when packing neck wounds to avoid airway compromise. Avoid encircling bandages around the neck. Packing penetrating head, chest, and abdominal wounds is contraindicated. So the next protocol, this is really exciting because this came from a lot of providers. It's Protocol 3.3, respiratory distress. There was a lot of providers that were contacting the OCMCA, not sure whether they should be giving albuterol first or albuterol and Atrovent. Dr. Cooper, can you speak to the changes in this protocol and how they affect the EMS providers?
This is a very exciting change in this protocol. Now, paramedics, first line, will be able to give albuterol and ipratropium, which is exactly what we would be doing in the hospital anyway. So this is good care for the patient.
And it's been packaged in this new format that's much easier to read with 2 columns. EMTs do this, paramedics do this. And for protocol 4-5, pediatric respiratory distress, failure, or arrest, similar change and quite a large change for the treatment of pediatric patients above the age of 2. Dr. Cooper, what are your thoughts on this one?
So my thoughts, I really like this a lot. I think this is excellent for the care of the patient. And frankly, it's the same care that the patient would get if they came to the emergency department. And that is that we are now allowed to use ipratropium all the way down to the age of older or equal to 2 years of age, which follows many, many national guidelines, including the NASEMSO guidelines.
Pediatric seizures, which is 4-7. There's no changes. It's just cleaning up the language to make it more readable.
5.3, tachycardia, has an important change that Dr. Cooper will give his thoughts on.
So the change in this protocol is for a irregular and narrow complex tachycardia, we are no longer using amiodarone. And the reason for this, and this has been discussed extensively, is that amiodarone, what it does is it would control the rhythm as opposed to the rate. So the rhythm control would be where this patient would possibly be converted back into a sinus rhythm, which would put this patient under certain circumstances at a very increased risk of having a stroke at that point. And so therefore the amiodarone was taken out of the protocol. Amiodarone is still in the protocol and should absolutely be used in a patient who has a regular wide complex tachycardia, where you're thinking VTAC or something like that. The previous dose of 150 milligrams over 10 minutes is still the appropriate dose, and it should be used in that situation.
Protocol 5-5, chest pain and acute coronary syndrome. The Oakland County Medical Control Authority has received several comments regarding the order of operation on a chest pain patient. This protocol answers those requests for change to put the treatment of a chest pain patient in the order that you actually provide it in the field. There's also a slight change to the administer oxygen language for keeping the SpO2 between 94 and 98%.
Protocol 7.1, 12-lead ECG, has changed quite substantially. Dr. Cooper, what's your thoughts?
So the biggest change in this protocol is that some of the language was changed to EKG must be performed in a lot of different situations. So please read through this protocol and know all the situations where you have to do an EKG. For example, every single patient with abdominal pain now needs an EKG, not just upper abdominal pain. You know, it's interesting because this is kind of how we operate at the hospital also. The EKGs get done a lot more often on patients with various complaints. And occasionally you'll be surprised. You'll find a patient with a complaint that you think is something completely different. You get the EKG and look at that. They're having an ST elevation MI and you just picked it up. So EKGs now must be performed in a lot of these situations. Additionally, number 2 in this protocol now says that patients exhibiting any of the following signs or symptoms must have a 12-lead EKG. Previously it said should, now it's must. And these symptoms include things as nausea, vomiting, diaphoresis, dizziness, or even a patient who just expresses a feeling of doom must now have an EKG.
As always, by a paramedic's clinical judgment, even in the absence of the symptoms above, should perform a 12-lead EKG if they feel it's necessary. And one of the other interesting things is this protocol now allows for the alternate placements of EKG leads. So the classic 15 and 18 lead EKGs where you're going to do a right-sided look or around the back. Some of you have seen this in some classes you may have gone to. And now the protocol allows for it. Prior to this, the protocol didn't allow for that.
And I just want to point out that the alternative 12-lead EKG placements are very specific. So if you have ST elevation in leads 2, 3, and AVF, then it allows for a patient to have a right-sided EKG. Or if you have ST segment depression in leads V1 through V4, then that could be a posterior MI, and that now it allows for them to have a posterior 12-lead.
For patients that meet the criteria of initial 12 lead, you should leave the leads in place. You can repeat the 12 lead every 5 to 10 minutes, and devices that have active ST segment monitoring do not require repeat EKGs unless there is a noticeable change in the patient's condition. So protocol 7-8, electrical therapy, talks a little bit about vector change. Dr. Cooper, what's vector change?
So what this protocol now allows you to do is, if you have a patient who is in refractory VFib after 3 shocks, then you can consider doing double sequential defibrillation. Double sequential defibrillation, there is a protocol for that. Just be mindful that if you're going to do that, make sure that your manufacturer's warranty will not be voided by doing that. Additionally, if you have refractory VFib after 3 shocks, you can consider changing the vector, which means that if the pads are, let's say, in the anterior-posterior position, then you can put a new set of pads in the anterior and lateral position, just changing the positioning of the pads. Or if they're in the anterior and lateral position, you can put a new set of pads in the anterior-posterior position. And then if after the 4th defibrillation, you still have a shockable rhythm, please contact medical control for potential early transport.
Protocol 7-8S, the electrical therapy double sequential defibrillation protocol. This is a paramedic only protocol. Previously, we didn't accept this protocol. Now we have. This is an optional protocol. That means agencies can choose to use it or choose not to use it. If you intend on using this protocol, you must train on this protocol, and it must be more of a training than what you're getting on this video. You should sit down and train to this protocol. If you have any concerns about your device warranty, refer them back up to your EMS coordinator or administration.
Protocol 7.11, impedance threshold device or ITD protocol, is optional. This is a new protocol, not so new for those who have been around a long time, if you remember the special study that this was part of. But we do have it back now from the state, and it will be an optional protocol for each agency to choose or not choose to implement it. If your agency chooses, you must train on it.
7.19, patient refusal of care. Patient refusals must be completed by the crew member with the highest level of licensure. There is one exception, however, in a specific situation.
And that situation, Amy, would be if you have multiple patients. Please review the protocol for details. Protocol 8.3, transportation protocol. It was a fixed reference. That's all we had to change. Protocol 8.7, ALS to BLS transfer of care, has changed to now include if you're transferring care to a BLS provider in the same unit. You can transfer care to the EMT in certain situations. This isn't new. Protocol 8.16, the explanation is not very clear in that protocol. And it was asked of the medical control that we clarify the language so there's some understanding of when an ALS provider can transfer care to a BLS provider for the ride out to the hospital. Dr. Cooper, can you help us understand this a little bit more?
Yeah, so I mean, the first thing in this protocol is pretty obvious, but it's there, that the EMT has to be willing to accept the patient. And then the protocol basically goes through other things that would make you uncomfortable transferring the patient. You know, the patient has to have a patent airway, the patient's hemodynamically stable, all the things that are pretty self-explanatory. When it says that the patients who receive an ALS assessment for example, a 12-lead EKG may be transferred to a BLS crew. The exception to that is a patient who is experiencing acute coronary syndrome symptoms. This is a very broad category. If you look at the 12-lead EKG protocol, which talks about patients who need these 12-lead EKGs, presumably because they're having acute coronary syndrome symptoms, it's a very broad categories: chest pain, abdominal pain, syncope, shortness of breath, any pain in their jaw, neck, shoulder, arm, any nausea, any vomiting, any diaphoresis, any dizziness, or even patients experiencing feelings of doom. Just be cognizant of all of that when you're thinking about transferring care. These are all things that you need to be thinking about that could end up being cardiac in nature or acute coronary syndrome. I also want to point out, for refusal of care, the ALS crew member must be the one to complete that refusal form and the EPCR.
8.10, infection control. The change here is that when you use a BVM, you must don a simple mask if HEPA filtration is present on the BVM. If not, the crew must wear an N95.
Protocol 8.15, interfacility transfers, is just a change in the yellow box that allows for BLS providers to transport additional patients between facilities.
8.19, unseen physician or non-physician provider interaction. So the name has changed, because it used just to be, if you had a doc on scene, this is what you did. Now you may have any number of different types of non-physician licensed providers that you may be interacting with, such as a midwife. On scene, she's taking care of the patient, she's delivering the baby, something goes wrong, and she ends up calling 911 for your help. She can be very helpful on the scene for you. She knows her patient and what's going on. So you can utilize her. You could actually even have her transport with you. That's the whole intent of this protocol, and how we changed it is to allow those people who are already attending to the patient to be able to help you guys on scene and even go to the hospital with you. Just like a physician can. No change other than we're allowing for licensed non-physician providers.
Protocol 8.103, abbreviations, has been deleted.
Protocol 9.1, medication administration, just cleaned up some typographical errors. Thank you, everybody, for listening to the provider education for the November 1st, 2025 rollout. If you have any questions, feel free to contact us. Take care.